it's a real honor and also a privilege to be giving the first ever Dr. William Chao Memorial Lecture. As Joseph told you, Willie graduated from Chiba, and he did his residency and consultancy in London, where he made acquaintances to some of the pioneers in therapeutic endoscopy. This is an old picture of Professor Peter Cotton and Christopher Williams presenting their book on therapeutic endoscopy to Willie. Professor Chao was very active in promoting education in therapeutic endoscopy, and he actually brought the Hong Kong Society and the Chinese Society of Digestive Endoscopy together. In fact, he founded the Hong Kong Society in 1984. Here you see a picture of him in front of the People's Great Hall in Beijing with Professor Chao, who was late Professor Chao, who was then the president of the Chinese Society. And you can also see Professor Wang Hongzhi from Beijing 301 Hospital, one of the pioneering ERCP endoscopists in China. And together we see Professor Sidney Chung and Joseph Leung, and both were inaugurating professors in surgery and also gastroenterology in the 1980s. Professor Chao traveled extensively in China to promote education, and he was also very active in the education Asia-Pacific arena. Here's a picture of late Professor Niwa and Professor Fujita, and they led Asia-Pacific Society for over decades. And I still remember fondly traveling with them to Vietnam and Thailand to do live demonstrations. Professor Chao went on to become the president of WEO briefly before succeeded by Professor Nagi Reddy. My talk today is really to tell you a little bit about how to manage recurrent bleeding, which is probably the most important adverse prognostic factors in the management of patients with acute upper gastrointestinal bleeding. This is data from the National United Kingdom audit. 13% of patients rebled, and of these patients, the mortality increases to 27%. So one of the management objectives, and perhaps the most important management objectives in patients with GI bleeding, is to stop bleeding and prevent further bleeding. And the current standards are, Professor Song published this paper some years back, either the use of hemoclips and thermocoagulations, and their efficacies are actually very comparable. This is a slide on bleeding control over 30 days with the pool-salt ratios of exactly 1. So in managing patients with bleeding, then you ought to review if the patient has received an adequate therapy. And we learned from these randomized control studies many years ago, then the surgical dogma was to take the patient to operating theater at the first sign of bleeding. And now following this trial, we've changed. We are now actually persisting with endoscopic therapy, and that surgery is slowly disappearing. Then we randomized 92 patients over 5 years, and we found that what we found was further endoscopic therapy, in fact, was able to control further bleeding within 30 days in 75% of them. And in this intention to treat analysis, we can see that by subjecting the patients to surgery, and these patients often have a lot of complications following surgery, and numerically the mortality was a little higher. And it was not a very good trial because of a small number, and yet it was very difficult to do. But from this trial, we learned that in majority of cases, we can persist with endoscopic therapy, and oftentimes endoscopic therapy works. And what are the newer endoscopic options? In this talk, I'm going to talk about 2 options which we have more experience with. The first is the use of Hemospray. The other is the use of the over-scope clips, or OTSC. Professor Joseph Song, the chairperson to this session, in fact, collaborated with Johns Hopkins Hospital and the Cook Company, and he reported the first human application of this powder. And this powder is actually power-driven onto the bleeding point, and this is a carbon dioxide canister. And it actually is a very, very simple solution. In that particular trial, we enrolled 20 patients with actively bleeding ulcers. And in 95% or 19 of 20, we were able to stop bleeding for a period of 30 days. And you can see that this is, in fact, a very simple option. The powder is made of mineral blend. It's actually a mineral blend powder with the main ingredient of aluminum silicate. It was, in fact, FDA approved for external use in stopping hemorrhage from civilian and military wounds. So this was, in fact, adopted for the use in gastrointestinal tract. This is a video, an old video where we had a lot of difficulty controlling bleeding from an angular ulcer. And after a little while, we took out this Hemospray, and we power spray this powder onto the bleeding point, and we observed the area for about 5 minutes. And initially, there was some bleeding underneath the powder, and slowly, the redness or the area did not enlarge, and we observed the area for a period of time, and there was no more bleeding. And we took the patient back the second day for a second look, and then we could see that the powder had completely been washed off, and leaving some remnants of the bleeding artery, and then we could actually choose to apply a second therapy targeting at the bleeding vessels. The use of Hemospray as a rescue therapy, I think is a useful treatment. If you fail to control bleeding, the Hemospray is a useful adjunct. And in this Spanish study, a multi-center study involving 21 centers, where 261 patients were treated, and 73% of patients, Hemospray was used as rescue therapy, and with a rate of successful hemostasis of 93%. The rate of recurrent bleeding at day 7 was high, so it's generally advised that having stopped bleeding with Hemospray, you take the patient back to apply further therapy. We are publishing this study. We compare Hemospray to standard therapy in a variety of nonvariceal causes of acute upper gastrointestinal bleeding. And we are at a stage of publishing this when we designed this with the hypothesis that Hemospray would not be inferior to the standard therapy, which was clips and thermocoagulation. And in fact, we found a difference of 8.7% over 30 days in favor of the use of spray. And the main difference was, in fact, the spray was superior in the initial control of bleeding that applies to ulcers, cancers, and a variety of other causes. So this is a video of OTSC. This is a case, difficult to control bleeding. We try heater probe. The heater probe came off, and then bleeding started, and we tried clips, and it didn't work. And in the end, we used OTSC, and you can see the nitinol clip actually mounted onto a transparent hood. In this case, because we needed to retroflex the endoscope, we used what we call an anchor device, which in fact puncture the ulcer base, and we can gently pull the ulcer into the suction chamber. And you can see a trip string at 6 o'clock, and by pulling the string, we deploy the clip, and you can see that the clip going around the vessel very nicely, controlling the bleeding, and that these clips tend to stay for a long time, and often at the end of several months when you actually do an X-ray, the clips will still be there. So clip retention is almost 100%, and with a large amount of tissue being incorporated, and that the bleeding control is in fact very secure. This is another case, an elderly woman, and in the background you can see through the scope clips falling off, and there have been studies looking at clip retention, and it's most of other clips, the retention rate is actually quite poor. And again, we see here the use of OTSC, where we can use the chamber to scan the area, and then we can see the artery very clearly within the chamber, and gentle suction and pulling the string and deploying the OTSC, and this patient's post-endoscopy recovery was eventful. So the best study to indicate that OTSC should be applied in patients with recurrent bleeding came from a multi-center German group. In fact, our hospital contributed several patients. The study was called the STING study, or Stop Bleeding study, where we randomized 66 patients. The primary endpoint was bleeding control over 30 days, which was further bleeding occurred in only about 1 in 6 patients after OTSC. Remember, these were patients with refractory bleeding, and further bleeding in the standard therapy group was as high as 57%. So we now have good evidence that OTSC should probably be the treatment of choice in refractory bleeders. So increasingly, we see OTSC being used as a primary therapy. This is data from the Mayo Clinic, where they used OTSC in 49 patients, and they selected the high-risk patients, and of course Mayo Clinic was a referral center, so they would use OTSC as primary treatment in ulcers near a major arterial complex. This is the bulbar ulcers and ulcers in the lesser curve and angular notch, with an artery greater than 2 millimeters in size, deep penetrating ulcers, and fibrotic ulcers. The control of bleeding over 30 days was 70% in the series. And here I can show you an example of such a patient, and this video belonged to an Indonesian lady. She bled came to us with a hemoglobin of 3 grams per deciliter. When we put the scope in, there was huge vessels with a very large bulbar ulceration. And obviously the treatment of choice is the use of OTSC, and here you can see the clip being applied. It's very easy. In applying these clips, you don't need to apply a lot of suction. You just have to scan the area and cover the area. And here you can see a very nice picture at the end of therapy. The use of angiographic embolization, if you refer to the National United Kingdom data, increasingly this is being used in place of surgery. Here I show a video of angiographic embolization to the gastroduodenal artery, and not easy to see. There's a microcatheter from the main catheter going into the GDA, and you can see clips apply during endoscopy to indicate the area of bleeding, and then you can see coils within the GDA proper. One of our fellows, who is now a consultant at the Imperial College, did a meta-analysis of retrospective series that compare angiographic embolization to surgery. And we tried to do a RCT, which was not very successful, because for many years patients would not consent to surgery, knowing the prospect of the possibility of angiographic embolization. So here you can see that mortality following angiographic embolization was in fact marginally lower than that following surgery. Of course, we have to consider the quality of the data, and these were retrospective series. It's noteworthy that angiographic embolization carries a very high rebleeding risk. In this meta-analysis, you can see the rates of recurrent bleeding following angio. It was 28%, which can be understood. Here you see a schema to show that GDA actually reduced due arterial supply from both the celiac artery and also the superior mesenteric artery. And often after angiographic embolization with rebleeding, and sometimes the radiologist will need to come back and then and do therapy through the SMA, and this is a real possibility. And to the right-hand picture, you can see a coil protruding through the GDA, the gastroduodenal artery proper. And perhaps the way forward is to offer a prophylactic angio in patients with very high-risk ulcers. And we published this study in the Journal of Gut. There was a problem in the design of the study, and as the overall group, we were not seeing a difference, but in this post hoc subgroup analysis, and if you can see that in patients with large ulcers arbitrarily defined by those greater than 15 millimeter in size, and without angio, the rate of recurrent bleeding would be about 23%, and with added angio, it actually went down to about 4.5%, and you calculate the number needed to treat, which is about 5. So I think it's a good message, except that this may have to be confirmed by yet another randomized control studies. So here's one example. This patient was in fact in the prophylactic trial. I was asked to see because the patient had a very fibrotic bulbar ulceration. We tried putting clips on and they kept falling off, and then we irrigated the area with the irrigation port of a heater probe, and we find this artery which was approximately about 3 millimeter in size, and we went on to treat the bleeding, and to prevent recurrent bleeding, we offered patient angiographic embolization to the GDA. We dropped coils distal to the bleeding point and put some gel foams in between, and then some more coils in the proximal portion of GDA, and we call this a sandwich technique, and the patient's recovery was uneventful. So in conclusions, I've presented evidence that we should probably persist with endoscopic therapy. That would be in the best interest of the patient. I think the surgeons will hate me, and I'm a surgeon as well, but I think endoscopic therapy is the way forward. I think OTSC or Hemospray useful as rescue therapy, and that if the patient is bleeding, and then we should really consider angiographic embolization before surgery, and increasingly we offer prophylactic therapy to patients with large ulcers who have had a significant bleed. Thank you very much.